Welcome to the Deep Dive. We tackle complex topics and, well, give you the shortcut to really getting it. Today we're diving into something quite fascinating, almost a paradox, really. How do surgeons operate not just to, take out disease, but to carefully, meticulously preserve a person's quality of life? Amazing when you think about it. Beneath all the visible organs, there's this hidden blueprint, an architecture that, well, it guides surgical success. So our mission today: uncover that blueprint. We're taking a deep dive into the world of pelvic fascia and nerves. Think of them as the unsung maestros, maybe the architects of precision in surgery. They dictate everything: continence, fertility, just the ability to live a full life after surgery.
Exactly. And this deep dive, it's your direct path to understanding these, frankly, incredibly complex anatomical roadmaps. We're going to demystify the structures behind huge procedures like total mesorectal excision TME. The goal is always twofold: complete cancer removal, what we call oncological completeness, and protecting those vital functions. We'll unpack the critical distinctions, the delicate balances you need to understand. It's more than just names.
Right. And that's why we've gone through, well, quite a stack of sources, detailed surgical texts, the latest research, expert insights, distilling it all down for you. So let's get started. Well, first things first, let's get our bearings. We're calling it the pelvic compass. Expert, I've heard surgeons visualize the pelvis less like a cavity and more like a meticulously designed room. Can you walk us through that? Why is that image so helpful?
Absolutely. Thinking of the pelvis as a room, it provides an immediate, essential mental map. It helps surgeons stay oriented in what can be a really confined, complex space. So imagine it's four walls. Anteriorly, up front, you've got the pubic symphysis and the bladder.
Yeah.
Posteriorly, towards the back, the sacrum and the rectum. Laterally on the sides, the pelvic bones and muscles like the obturator internus.
Got it.
Then yes, there's a ceiling. That's the peritoneal reflections coming down from the abdomen. And the floor is the strong pelvic diaphragm. It's not just anatomy, it's a 3D puzzle. You really need an architect's eye.
That makes perfect sense, like an internal GPS. So within this room, who are the main architects? What gives it that structure? What do surgeons look for first?
Well, that brings us straight to one of the most critical structural players, the parietal pelvic fascia. You can think of it like the wallpaper of our pelvic room.
Wallpaper, okay.
Yeah, it's a robust, dense layer of connective tissue, lining the inner bony walls and covering the muscles inside the pelvis. It's actually a direct continuation of the transversalis fascia from the abdomen.
Ah, so it comes down from higher up.
Exactly. But as it descends into the pelvis, it thickens up quite a bit. And that thickening is key. It covers muscles like the obturator internus, piriformis, levator ani, plus the sacrum and coccygiosis. But the crucial point for our deep dive is this. This fascia isn't just lining. It's vital for organ support. And most importantly, it defines the clear, critical surgical dissection planes, the pathways, essentially.
Okay, so the parietal fascia is the wallpaper defining the room's boundaries. But what about the organs inside the room? Are they just sort of floating there, or is there another layer? This is where I sometimes get a bit lost.
No, that's a really important distinction. If the parietal fascia is the wallpaper on the walls, think of the visceral pelvic fascia as more like the delicate wrapping paper directly covering and supporting the organs themselves, the bladder, the uterus, the
Wrapping paper. Okay, I can picture that. Thinner.
often thinner, yes, more pliable. Now, here's where it gets really interesting and a bit complex. The visceral fascia actually starts as a continuation of the parietal fascia, draping over the organs. And in certain places, these two types of fascia can fuse together, creating even more significant structures.
Okay, so one on the walls, one on the organs, and they can connect or fuse. Got it. But then there's another term I always hear, the fascia propria of the rectum, sometimes called the mesorectal fascia. How does that fit in? Is it just more wrapping paper?
Now that distinction is absolutely paramount. The fascia propria of the rectum is not just another wrapping paper. Think of it as a specialized, super condensed part of that visceral fascia. It's like a custom-fitted, tight capsule.
A capsule.
Yes, specifically encasing the entire mesorectum. And the mesorectum, just to clarify for everyone, is that fatty envelope around the rectum holding all the lymphatics, blood vessels, nerves, everything associated with the rectum itself.
Okay, so it's a package deal around the rectum.
Exactly. And the profound surgical insight, especially for TME, is that this fascia propria is the boundary you must respect. The absolute surgical imperative is to dissect precisely between the fascia propria of the rectum, that's the visceral bit you remove with a specimen, cancer and all, and the parietal pelvic fascia, the wallpaper, which you must leave behind. That distinction, that specific plane, is the bedrock of safe, effective surgery.
That clears things up immensely. Fascia propria is the Holy capsule around the target. Parietal fascia is the wall you stay outside of. Okay, it helps to have almost like a surgical cheat sheet for these layers. Can you quickly recap the main players in this fascial framework for us?
Sure thing. Let's try that. First, fascia propria of rectum. Think shiny white capsule, innermost visceral layer around the mesorectum. This defines your holy plane of rectal surgery. It's the target's boundary.
Okay, shiny capsule, holy plane.
Next, mesorectum. That's the lymphatic office of the rectum, the fat-filled package itself, crucial for cancer clearance, getting those nodes.
Lymphatic office, got it.
Then visceral pelvic fascia, this is the broader term. Think protect the temple of pelvic organs. Covers organs generally, but it's not usually a dissection plane itself.
Wait, the general wrapping paper.
And finally, endopelvic fascia, maybe the architectural backbone of the pelvis.
Mm-hmm.
A thicker, sort of investing fascia, including both parietal and visceral parts. It condenses to form key ligaments like Waldeyer's fascia, which we definitely need to talk about.
Excellent. So we've mapped the architecture, the wallpaper, the capsules. But where do surgeons actually cut? Where are these holy planes everyone talks about? These sound like more than just spaces. They're definitive borders, right?
Exactly. They are the sacred ground of pelvic surgery. Let's explore them. First, perhaps the most famous, the holy plane of Heald, the vascular sanctuary.
Heald, holy plane. Okay.
The profound insight here from Professor Heald wasn't just about getting the cancer out cleanly. It was realizing that by following this natural, almost bloodless pathway, surgeons inherently shield the delicate nerves nearby, nerves critical for function. It's sort of a surgical paradox. The path of least resistance is also the path of greatest preservation.
Wow. So where exactly is this plane?
Fundamentally, it's located between the fascia propria of the rectum, that shiny capsule we just discussed, and the parietal pelvic fascia lining the sacrum, called the presacral fascia.
Okay, between the capsule and the back wallpaper.
Precisely. When a surgeon enters this plane correctly, it's naturally loose connective tissue. It's a vascular, meaning few, if any, blood vessels. This allows for a clean dissection. Clinically, staying strictly within this plane ensures you remove the entire mesorectum tumor, nodes, vessels as one intact package. And crucially, it preserves the vital autonomic nerves, the hypogastric and pelvic splanchnic nerves, because they lie outside this plane behind the parietal fascia. This directly means less risk of postoperative urinary and sexual problems for the patient. A huge deal.
A huge deal is right. Finding that bloodless path literally protects a patient's future function.
Okay, what's next on our map of these critical planes?
Next, we often encounter Waldeyer's fascia, the posterior tether and gateway. This is a significant thick band, a condensation of that presacral parietal fascia. Imagine a strong fibrous strap extending from the front of the sacrum, usually around S2 to S4, and inserting into the back of the rectum. It acts like a posterior tether or a suspensory ligament holding the rectum back.
So it anchors the rectum posteriorly. That's right. And here's the surgical point. During TME, Waldeyer's fascia must be sharply divided, cut cleanly. This is the gateway to entering and staying in that correct avascular holy plane below it.
What happens if you don't?
If you fail to recognize it or try to bluntly push through it, you can cause troublesome bleeding from the presacral veins right behind it. And maybe more importantly, you risk injuring the hypogastric nerves, which are very close by. It also functionally divides the presacral space. You usually find this structure about, 4 or 5 centimeters above the anal verge. Sharp division is key.
Okay, so Waldeyer's is like a locked gate. Need the right key, a sharp cut, or you damage the surroundings. Makes sense. What about the sacral promontory? I hear that mentioned all the time as a major landmark.
It absolutely is. We're talking about the sacral promontory. Keystone but fusion zone, a paradoxical difficulty. The promontory, that anterior lip of the S1 vertebra, it's undeniably a keystone landmark. It clearly marks the shift from the abdomen to the true pelvis, often the starting point for the posterior dissection in TME. It helps surgeons orient themselves.
Sounds straightforward enough. So what's the paradox?
The paradox is, despite being this key landmark, it's notoriously difficult for the initial dissection. Why? Because it's a fusion fascia zone.
Fusion zone.
Yeah, right at that spot. The visceral fascia covering the structures coming down and the parietal fascia lining the bone are often tightly fused. There isn't a clear, easy avascular plane right there. Instead, you find dense fibrous tissue, you find nerves, sometimes vessels, all kind of integrated.
So trying to start right there is asking for trouble.
It can be. The strategy here needs sharp, precise technique, not blunt pushing. A clever trick many surgeons use is to start the incision just below the promontory, maybe slightly off to one side, slightly lateral,
Why there?
because that often allows you to find and enter the emerging avascular plane just below the densest fusion part. You bypass the trickiest spot centrally and reduce the risk to those tightly packed hypogastric nerves and presacral veins right there. There's a classic aphorism surgeons use.
Oh, I like aphorisms.
Above the promontory, you're a collector of lymph nodes. Below it, you're a sculptor of nerves and fascia. It really captures that shift in focus.
That's brilliant. Collector versus sculptor. I'll remember that. Okay, what about the front? The anterior dissection.
Right, so for anterior dissection and Deneville fascia, the same principle applies. Find and follow the correct fascial plane. Deneville's fascia functionally is part of the visceral pelvic fascia system, but it forms this distinct anterior curtain.
A curtain.
Yes, a glistening layer separating the rectum from the prostate and seminal vesicles in males or the vagina and uterus in females. Staying meticulously posterior to this layer, behind the curtain, is absolutely crucial for nerve-sparing, safe cancer surgery, especially in low anterior resections. It protects the vital neurovascular bundles essential for things like sexual function, which run just anterior to it.
We've really charted the fascial landscape now, the layers, the metaphors, the tricky spots. But okay, let's shift focus slightly to the truly delicate maestros conducting everything, the nerves. Expert. What are the key nerve networks surgeons absolutely must protect?
Yes, the nerves are, well, everything when it comes to function. We're primarily talking about the autonomic conductors, sympathetic and parasympathetic nerves. First, the sympathetics. Think fight or flight.
Right.
They originate higher up, T10 to L2 in the spine, and descend into the pelvis via the superior hypogastric plexus. And that plexus sits right around that sacral promontory we just discussed, anterior to the sacrum.
Ah, so that difficult spot is nerve central too.
It is. These nerves then continue down as the hypogastric nerves, running sort of posterolaterally to the mesorectum. In the pelvis, they control things like vasoconstriction, they're involved in ejaculation, and they help the bladder relax to store urine.
Okay, and the parasympathetics.
Those are your rest and digest nerves, also called the pelvic splanchnic nerves, or classically, the nervi erugentius, the nerves of erection. They come directly from the lower sacral spine, S2 to S4.
Nervi erugentes. Okay.
These are crucial for bladder contraction, emptying the bladder, promoting bowel movements, and absolutely essential for erection through vasodilation. You generally find these nerves tucked away laterally in the pelvic spaces.
So fight or flight running down the back, rest and digest coming from the sides, do they like meet up somewhere?
They absolutely do, and it's at a critically important hub, the inferior hypogastric plexus. This is the main junction box, the mixed plexus in the pelvis. It receives both sympathetic input from those hypogastric nerves and parasympathetic input from the pelvic splanchnic nerves.
The main switchboard, you could say.
That's a great way to put it. It's the switchboard for almost all critical autonomic functions down there. And its location is key. It lies in the posterior pelvic space, lateral to the rectum and bladder, nestled within the pelvic fascia, along the side walls, crucially, just outside that parietal pelvic fascia, that wallpaper layer.
Ah, so respecting that parietal fascia plane protects this plexus too.
Exactly. This is a prime example of why knowing those fascial planes is function-saving. Injury to this inferior hypogastric plexus is a primary cause of postoperative urinary dysfunction and sexual dysfunction. A devastating complication. One wrong move here,
Yeah.
it changes everything for the patient.
That really underscores the stakes. Okay, beyond those autonomic controls, fight or flight, rest and digest,
Yeah.
what about nerves controlling actual movement and sensation, like continence?
Excellent question.
Yeah.
That brings us to the somatic movers and sensors, primarily the pudendal nerve. This one has a fascinating journey. It arises from the lower sacral plexus, S2 to S4, like the parasympathetics, but then it takes this distinctive route. It exits the main pelvic cavity through the greater sciatic foramen, loops around a bony landmark called the ischial spine, and then re-enters the perineum, the area below the pelvic floor, through the lesser sciatic foramen, finally passing through a little fascial tunnel called Alcock's Canal.
Wow, quite a trip. What does it do?
It's incredibly important. It provides the main motor supply to the external anal sphincter, the muscle you consciously squeeze, the external urethral sphincter, and most of the pelvic floor muscles, including the levator ani. Basically, it's critical for voluntary continence, your ability to hold it.
Okay, crucial for control.
And it provides sensation from the genitalia, the anus, the perineum. It has direct branches, the inferior rectal nerves that specifically go to the external anal sphincter and also give sensation to the lower part of the rectum. This lets you sense rectal fullness and contributes to that feeling of urgency. Damage here. That can lead straight to fecal incontinence.
It's just amazing how interconnected and vital all these structures are. Is there one area that surgeons are particularly cautious about, like a real danger zone for multiple nerve types?
Yes, there definitely is. For the really discerning surgeon, there's a specific area, almost a no-fly zone, that we sometimes call the Holy Triangle.
Holy triangle. Okay, what defines that?
It's a critical anatomical landmark,
Yeah.
a small triangular space, usually identified just above the pelvic brim. It's formed by the ureter running down as the lateral boundary,
Right. A tube from the kidney.
the vas deferens in males, or the uterine artery in females, forming the medial or anterior boundary, and the hypogastric nerve, one of those sympathetic nerves we mentioned, forming the posterior boundary.
So ureter, vasuterine artery, hypogastric nerve.
Exactly. This small corridor must be meticulously identified and protected. Careless dissection here puts urinary function, sexual function, everything at risk. It's truly a no-fly zone. There's another aphorism for you.
Lay it on me.
Respect the triangle, preserve the man. Or woman, of course, referring to function. And, all this just reminds us of that phrase you sometimes hear in surgical circles. What happens in the pelvis doesn't always stay in the pelvis, especially nerves. It's a constant, solemn reminder. The consequences of nerve injury are profound. Our responsibility for functional outcomes is huge. And maintaining that fascial integrity we talked about, it directly correlates with the patient's quality of life afterwards.
A really powerful and, yeah, sobering thought. But as with many things in medicine, this field isn't standing still, is it? It's constantly evolving. There are new insights, new technologies changing pelvic surgery. Expert, how are these advancements helping surgeons navigate the complexities we've just laid out?
They're making a massive difference. A huge one is preoperative planning with high-resolution pelvic MRI. Surgeons are now learning to read these scans almost like radiologists.
Seeing the roadmap beforehand?
Exactly. You can identify potential threats to the CRM, the circumferential resection margin, that safe edge around the tumor. You could see if lymph nodes look invaded or if there's distortion of the planes from scar tissue or previous radiation. This allows for incredibly precise planning. You can anticipate those tricky fusion zones, anticipate where nerves are likely to be before you even make an incision. It's like having surgical X-ray vision.
That's incredible. What about the surgery itself?
Well, that leads to advancements in surgical techniques, things like robotic rectal surgery. The magnification is amazing, the dexterity. It allows for much more precise nerve-sparing dissection, especially out laterally, where those key nerve plexuses are.
So fewer complications.
Significantly fewer, in many studies, for bladder and sexual dysfunction. We're even seeing new concepts like the nerve window technique, where surgeons actively use the robot's view to find, identify, and meticulously protect nerve bundles. And we're pushing boundaries beyond standard TME, things like ultra-TME or extended mesorectal excision for more advanced cancers, focusing on precise dissection right down to and sometimes below the pelvic floor.
Wow.
And those difficult areas, like the sacropromontories fusion zone, we now look at the pre-op MRI to anticipate these mesofascial transition zones, which might guide a strategy like starting slightly off midline to find that safe plane more easily. It's becoming much more strategic. And finally, it's broadening out to the broader picture, functional pelvic anatomy and prehabilitation. It's not just about the operation anymore. There's a much bigger focus on understanding how structures like the levator animuscles recover, how the anorectal angle is restored.
So recovery is part of the plan.
Absolutely. Even things like prehabilitation pelvic floor training before surgery can help patients regain continence faster and improve their overall functional outcomes. It's really about the whole journey, ensuring patients can lead a dignified, fulfilling life afterwards, not just surviving the cancer, but truly thriving.
So wrapping this all up, what does it really mean? We've journeyed through this incredibly complex landscape. We've seen that these fascial layers, the parietal, the visceral, they aren't just anatomy textbook entries. They are the definitive, sometimes subtle borders surgeons navigate. Mastering their nuances, where they come from, how they relate, those tricky fusion zones, and how they define those crucial avascular planes well, that seems to be the true hallmark of a skilled pelvic surgeon. It feels like it directly addresses that paradox we started with, the difference between just removing disease and ensuring a patient walks away whole with their function intact.
Precisely. It's a powerful testament, really, to how deep anatomical knowledge translates directly into patient outcomes. It ensures not only that clean oncological resection, giving the best chance against cancer, but also safeguards bladder, bowel, sexual function, preserving dignity, preserving quality of life. This deep dive hopefully has given you a shortcut to grasping that profound surgical responsibility.
And here's where it gets really fascinating, maybe a final thought for you to chew on. If these intricate, almost hidden roadmaps exist within the pelvis, just waiting for meticulous dissection and understanding to unlock life-changing surgery, well, what other anatomical secrets does the human body hold? What other profound insights might be lying just beneath the surface, waiting for us to decipher them and truly revolutionize medicine and patient care? Keep exploring, keep questioning.